right. Good morning once again, everyone. Such a thrill to be here in person with all of you. My name is Bob Crookton. I am the vice chair of the board of the ABTA. It has been my absolute honor to be involved as a volunteer with the American Brain Tumor Association since 1998. I went to Catholic schools all my life, so my math skills are not that great, but I did have a brainstorm, no pun intended, yesterday coming over here that I've been involved for half the time that the ABTA has been in existence. So that's pretty amazing, and it's really been my life's honor. I had a great friend of mine, my best friend Paul Fabry, pass away back in 1998 from a glioblastoma that he fought very courageously for 10 years. And he lit a fire under me. You hear a lot of people takes sort of late bloomers like myself a while to find their why, right? Everybody talks about finding their why. Well, I found my why at the age of 21 when, as an all-conference basketball player, Paul was a picture of health, collapsed working out at Bally's one afternoon, and again, courageously fought a glioblastoma for 10 years, which was unheard of in 1998 and unheard of in 2023. But enough about me. We're here to talk about preserving cognition and emotional health. I want to acknowledge, going back to really the pillars of what we do here at the ABTA. I want to acknowledge Don and Gail Siegel are here today. They got involved with the ABTA back in 1975. So you talk about Mount Rushmore of the ABTA, they are definitely on it. Their son was diagnosed in 1975, and obviously a different world back then as far as resources and sharing and collaboration, and really we're on an island. So they were awarded, while we've been here at the conference, the Joel A. Gingras Jr. Award, which is the highest honor that a volunteer can receive for the ABTA. So Mr. and Mrs. Siegel, thank you for being here. So I promised, without any further ado, I want to introduce Ashlee Loughan, Ashlee Loughan. She is the Associate Professor of Neurology, a clinical neuropsychologist at Virginia Commonwealth University. We're going to bring up Ashlee to talk about preserving cognition and emotional health. Ashlee?
Thank you. Hi, everyone. Can you hear me? I probably actually don't need this. I tend to be a projecting speaker. My husband calls me loud. Thank you. I'm so honored to be here. Thank you to the ABTA. And actually, I want to share with you guys before I get started that this is probably one of my most favorite conferences. As an educator, as a researcher, as a clinician, it's part of our job in academia to go and speak. And so we're used to speaking with our colleagues. Speaking in front of patients and the caregivers is why we do what we do. You guys are why we do what we do. So I want to say thank you. I'm excited to be here. And I hope at the end of this session, you guys grab a couple pearls of wisdom to go back to your homes and to enjoy and fulfill the life that you've been given. Okay, so the agenda for today, I'm actually going to talk about two different topics. You guys saw in the title, I'm going to talk about cognition, and I'm going to talk about psychological or emotional health. So we'll start with cognition, and then we will jump into emotional health. So let's talk about cognitive impairment. 90% of our patients with brain tumors report cognitive concerns to us. And in the medical world, you'll see these fancy terms, cancer treatment-related cognitive impairment, chemotherapy-induced cognitive impairment. That's not what my patients say to me. They tell me, I am living in a mental fog. I see heads already shaking. Yes. I have quote-unquote chemo brain, I think. And my favorite that I hear the most often is I just feel like my brain has become mush. So why is this? It's actually not surprising given all that we put the brains through during this treatment. So we know that the tumor itself can cause damage to the brain. It is in there in a place where it's not supposed to be. It's pushing up against other structures. There's swelling in the brain. And then we go in and we cut it out, right? So obviously, that's a great thing as far as the tumor, getting as many cells out as possible. But when you go in with a knife or a blade, you're gonna cut things that aren't meant to be cut. And then we force you to undergo aggressive treatments that are life-sustaining, but also have negative impacts. So targeted radiation therapy, as you can see through time, 1 month after radiation. If you notice, there's these white edges starting to build up 6 months after radiation, 12 months after radiation. You notice scar tissue has started to damage the brain structures. And then on top of that, we add in chemotherapy. This is actually a famous picture taken from a brain cancer survivor. I'm sorry, a breast cancer survivor. So these are twin brains. One of the twins had breast cancer and chemotherapy, one did not. They put him in a fancy MRI machine and they had him do a whole bunch of problem-solving tasks. And this is where we learned that you see on the right, more lighting up means that more activity is happening. What we learned is that it's actually not the chemotherapy making your brain not work, it's that you are having to work harder to perform the same tasks that used to be easier for you. So I tell my patients all the time when they say my brain's not working, I say, that's not true. It's working 10 times harder than mine's having to work. So give it a little bit of credit. And then we are giving you medications that are also neurotoxic. You have edema, we're giving you steroids, which might help your day-to-day functioning but have negative cognitive effects. And then obviously we know that seizures are high risk in brain cancer patients, and we give you anticonvulsants, also have neurotoxic effects. So all of these things we're doing to your brain, it's no wonder that our patients are coming and saying, my brain is not working as well as it used to be working. So what does it look like in your day-to-day life? What does this mean? I'm gonna ask for a little bit of participation. I want you to raise your hand if you or your carer has experienced this. Daily forgetfulness. I hear it every day. Yes, look at all those hands. Distractibility. Word finding, tip of the tongue, I know what that word is, I can't come up with it. Inability to multitask. Don't distract me because I'm not gonna come back. I see some hands are just staying up there. I love this. Slowed thinking. I can get it done. It's just taking me 2 to 3 times longer to do it. Disorganization. I have no idea how to prioritize the tasks that I'm supposed to complete today. This is what I'm hearing from my patients, obviously what you guys are experiencing. And what does this impact? Honestly, I don't even need to put anything up here because what I want to say is every single thing in your life this impacts. But there are some statistics that I want to go over with you guys. This is shocking to me. I read this a little while ago. 1 year out from a brain tumor diagnosis, only 1/3 of patients were able to return to work due to the high levels of impairment that they were experiencing. Also, we know a lot of our patients aren't able to drive, which limits your independence. So seizures will reduce a person's capability of driving. Some states even have laws that I know in Virginia where I come from, if you've had a grand mal seizure, 6 months, it doesn't matter what the anticonvulsants are doing. It doesn't matter how well you're performing. You are out of driving for 6 months. No questions asked. And then obviously cognitive impairment, which we just went over. But actually the shocking part is even though we know this, a lot of physicians aren't using formalized testing to see if a person can drive or even talking to them about driving. And then financial stability. Out of all of the oncology diagnoses out there, brain tumors incur the highest per patient initial care costs and then the highest per patient last year of life care costs. So imagine I'm telling you, you can't drive, and now you're unable to work, and you have the highest costs possible. So really why we're here, what can we do to preserve cognition? I'm gonna start with exercise. If you leave with nothing else, I want you to walk out those doors and realize that movement is your friend, okay? It helps promote physical health, but it also helps promote your brain health. It improves the blood flow to the brain, and it actually reduces the loss of the brain with aging. I want to tell you about a study. I'm not going to go into all the intricacies of the study, but I think it's a good takeaway message. This study was done probably about 10 years ago, and these are in healthy aging adults, okay? People with no brain cancer diagnosis or brain tumor diagnosis. And what they did was they followed these older 60, 70-year-olds adults over a year. They gave half of the adults a moderate exercise regimen. And when I say moderate, I don't mean they're out doing CrossFit. I don't mean they're out running a marathon. They're walking vigorously. They're doing some light weights, things you can do within your own home. And then the other half, they had them do a stretching regimen, okay? And what they did was they not only tracked how they were feeling, they tracked their thinking, their memory, but they also looked at the size of the hippocampus. So for those that don't know, hippocampus is a part of the brain located in the temporal lobe, and it is where our memories are learned and preserved, okay? So it's very important for memory. We need our hippocampus. They tracked it over a year. Those that did the moderate exercise, again, walking, light weight training, their hippocampus got bigger. Their memory improved. Those that just did the stretching, their hippocampus got smaller, and their memory reduced with typical aging, okay? This is important to know, movement, movement. And then obviously I always have to say when I give my talks, this doesn't mean that I'm telling you to go out and run a marathon tomorrow. Talk to your healthcare provider, make sure you're doing it safely for what your body is physically able to do. But any kind of movement, chair yoga this morning, that's important. If that's what you can do, get out there and do it every single day or when you can. Okay. I'm also going to talk about medicines because we have started to research, the field has started to research some medicines to see are there any that are going to preserve or help our brain with thinking after these treatments. So let's talk about memory because that's kind of the theme that we're on right now. A lot of the memory enhancers that have been investigated actually have been investigated for dementias and Alzheimer's, but they're starting to be looked at in our brain tumor patients. We've noticed that a medicine called Aricept has positive effects on mood, cognition, and quality of life, and also a medication called memantine. This actually has been shown to protect the brain during radiation therapy, and a lot of physicians are starting to prescribe this at the start of radiation up to 6 months after radiation to preserve some of those memory skills. And then our attention medications. Anybody heard of ADHD? Yes, we are finding that some of these stimulants that we give to 5-year-olds, 10-year-olds, 20-year-olds that have been diagnosed with ADHD are also helping our brain tumor patients. Not surprising, the frontal lobe is it's actually the largest part of our brain. It is important for our attention, our speed of thinking, our ability to executive control, multitask. And these are all areas that kids with ADHD have challenges with. Well, our brain tumor patients are also having troubles with this. So we're noticing that our patients that we're giving them to are reporting improved attention and improved processing speed. There's also a possible benefit on fatigue. We're still investigating this. But these are the medications, Ritalin, Adderall. I put this up here because everyone always asks me about medicines. I also want to say a caveat, always talk to your prescribing provider about contraindications with these medicines. For example, the attention enhancers, if you are having active seizures, if they are not controlled, do not take an attention enhancer because it is going to increase your risk for steroids. If you have high anxiety, which we'll talk about in a little while, do not take Ritalin or Adderall. It is going to ramp you up and possibly even throw you into a manic state. So there are contraindications for some people. They are beneficial, but you really have to have everything else controlled before you can try to insert this into your medication regimen. What I talk to my patients the most about is actually not medicine. I talk to them about daily living strategies. And what I tell them are, you know that saying, everything I learned or that I needed to know I learned in kindergarten? Do you guys know that like famous quote? I kind of feel like this for these daily living strategies because my patients will say to me, but that was so easy. And I said, but did it change your life? And they're like, it did. It truly did. And I tell my patients when I first meet them, which is like a week or two of diagnosis, insert these strategies now. Do not wait till you need these strategies because then it's going to be harder to implement them. If you get them as part of your regimen now, they will be like routine for you, and they will start helping you out before you even know that you need them. So we're going to take these by domains. I'm going to start with some attention strategies that I believe help my patients in their day-to-day life. The first one is take in small chunks of new information. So I want you to forget the good old days of being able to take in 6, 8, 10 new pieces of information at once at any time. I want you to think 2 to 3 pieces of information is all I can take in before I reinforce it, I learn it, and then I go to the next 2 or 3. If you overwhelm your brain, you're setting yourself up for failure. Also minimize distractions, okay? Again, possibly gone are the days where you can sit around and do a task while your entire family is in the kitchen. Or possibly gone are the days that you can sit in a large office with cubicles everywhere and buzz going around and people walking in and out. You really need to set your mind on focusing on the task at hand. So I tell my patients, try to get an office with doors, right? Maybe no windows even, just while you're working. Put on just headphones that minimize the noise. There's great headphones out there you can buy on Amazon that you can't hear anything around you. They are really helpful. And also, one task at a time, okay? Our brains actually weren't set up to multitask. We as a society have created that. And so focus on one task at a time and advocate for yourself. Tell your loved ones, tell your coworkers, I can only do one thing. So I'm going to do this right now. Just give me a minute, and then I will turn to you when I'm done this task at hand. Memory. I tell my patients I want them to become parrots. So you know parrots, they talk, they repeat everything that is said to them. So I want you to start repeating information back to yourself, either out loud or in your own brain. And this is great. I actually talk to my patients and their carers that either are at work or have a partner that is helping them. And I will say at the end of a meeting or end of a conversation, right before you dismiss, say, can I just repeat back what I remember from this conversation? It's helping your memory, and it's actually pretty impressive from the other person listening. It's like, oh, they're taking this seriously. They want to make sure they're doing everything that I asked them to do. Or do it to yourself. If you don't have somebody else, I tell people all the time, if you're going into the grocery store and you need to remember 5 things, say those 5 things over and over to yourself as you're walking through the grocery store. You don't have to be actually talking out loud to yourself. You can do it silently so people don't turn and look at you like you're crazy. This is a big one. Incorporate context for all new learning. And this is actually really important for you carers out there to understand. So when I'm testing somebody's memory in clinic, I might give them random disorganized information, and then I'll give them information in a story and like with context around it. And no surprise, when I give it to them in a context, they do better. So learning how to, instead of just give them a date or give them a time or give them a task to do and expect them to remember it, frame it in a story format. Give them, our brain wants to connect and associate with old learning, right? Things that we understand. And so use that to your benefit and say, okay, I'm going to tell you something I need you to remember, and I'm going to provide it in this story or context so that you can attach it in your brain, and that will help you bring it back and retrieve it when you need it. Ask for recognition cues. Don't just ask for the answer. You guys have beautiful brains that are still working. You're here, right? So ask, can you cue me? Can you give me some details around that so that your brain is retrieving that, and you don't need somebody to just give you the answer all the time. Designate a landing pad. Does anybody lose objects in their house? Keys, phone, glasses? I know I do. My husband is famous for this. So we designate a landing pad. You can see this picture up here, keys, phone, wallet, mask. I've even had patients go out and buy a label maker and put a label of where these things go. This will help train you to put your things in the exact same spot every single time. And then set reminders and appointments for to-dos. Now this can be very frustrating, but it can also be your best friend. Use it to remind you to take your medicines. Use it to remind you to call your doctor. Set up appointment reminders for yourself. The alarm will go off, and do it in the moment. Don't just shut it off and go do something else. Okay, the last daily living strategies are the organization strategies. So this first one, I'm going to jump off this mic because I want to show you something. I forgot to bring it up. Because I don't practice what I preach. You guys see this? This is my life. I'm not kidding, it is my life. It has everything in there for me to function. At work, at home, in my volunteer organizations, everything goes in one single notebook. My patients tell me all the time, yeah, I write everything down. It's all over sticky notes, and it's here and here and here, and I can't remember where I put the sticky note. So I tell them, carry this with you everywhere. I don't carry small purses anymore. Like, gone are the days of the little cute clutches. No. I have like the large purses because this goes with me everywhere. It goes out with me on Friday nights. It comes to work with me because I need it. I write down everything. And this has been the thing that my patients have said has made the largest, most simple thing, made the largest impact in their life, having a single notebook, writing down notes to yourself. Also, on the same token, a single calendar. Stop having a work calendar. Stop having your phone calendar and the wall calendar at home. It's too much to keep up with. Have it all in one spot. I know sometimes if you're busy, it can look like a lot in one day, but it really is helpful to not have to be jumping back and forth, because remember, we talked about that's an area that is challenging to most of us, to be able to multitask, and you're forcing yourself to do that when you have multiple calendars. Create a consistent schedule, routine, routine, routine. And pill boxes are not just for our 95-year-old grandparents. They are very helpful. You guys are forced now to take a lot of medicines, not just at the morning and at night. A lot of people have medicines throughout the day that they have to take, and the pill boxes now are beautiful and designed for every person. Okay, I would be remiss, because I get a question about it every single time I talk about brain games. You guys heard of brain games? Okay. They can be a fun way to keep your brain active, but I'm going to quote one of my colleagues. He gave a presentation a couple years ago, and I loved what he said here. It's better than nothing, but it's not necessarily better than anything else. Okay? So what I mean by that is, if you're not doing anything else to keep your brain active, sure, it's better than nothing, but it's not necessarily better than the other things that I've already gone over in this presentation. Okay? What we have learned is that these cognitive exercises, usually they're on our phone, are really good at improving our ability to do that task on our phone. So I get really good at that video game. But these tasks aren't generalizing to our day-to-day life, unfortunately. And this is being shown over and over again in the research. And so I always say buyers beware. And the reason I say this is because these companies, again, while they're good, better than nothing, a lot of them are actually getting hit with some pretty large lawsuits, and I'm talking about in the millions of dollars, because they're giving false claims of what they actually can do for your brain. Not that they can't, they just don't have the research to support it yet. So just, these companies are very good at marketing, they're very good at pulling in, and people are spending, as a society, billions of dollars on them, and we just don't know yet if they're doing what they're saying they're doing. So just be a little mindful of that. They are fun. Candy Crush is fun. I get it. Okay, so, Wordle, yes, exactly. I'm not very good at it, but I like it. Okay, so I spent the first like 20 minutes or so talking about cognition. I told you a little bit about what we know. I talked to you about the strategies really quickly that I talked to my patients about. And now we're going to jump over to the exact same thing for emotional health, okay? And then we'll open it up to questions and we'll start conversation and dialogue. So we know that psychological distress is extremely high in oncology populations. But what I preach is that my patients with brain tumors are actually at a higher risk than other oncology populations. There is a direct impact of the disease, meaning the tumor and its treatments, on our brain functioning, which impacts our day-to-day living and impacts our quality of life. We know that there's a high certainty of disease growth or progression in many of our brain tumors. And despite all of our amazing scientists' ongoing efforts, there is no curative treatment right now known for especially malignant brain tumors. And even more than that, to date, there remains no standard of care for managing distress in neuro-oncology. So what do we know about the psychological distress of our patients? And afterwards, we'll talk about our carers' distress. We know that nearly all of our brain tumor patients report some symptoms of depression. And clinical diagnoses hit about that 30%. This is higher than the general population, which is only about 7%, and other oncology populations, which is 13%. So our patients are coming up with more severe depression at higher levels than other cancer populations. And we also know that generalized anxiety is a concern in our patients. About 30% of our patients report moderate to severe levels of generalized anxiety, obviously with heightened times around those MRI scans, which what you guys will probably know this term very well, scanxiety, right? The 1 or 2 weeks before the MRI. What I noticed multiple years ago was that this depression, this generalized sadness, and this generalized worry that I had been taught at school was not what my patients were reporting to me. There was something else that I was noticing, these other themes. They were telling me they felt repeated trauma every time they walked into that MRI machine because that's what diagnosed them with the brain tumor, right? Uncovered it. They were noticing changes in their relationships. They were questioning, what is my new life meaning now after a brain tumor diagnosis? What is my purpose in life? And all of a sudden, this fear of the future, am I not going to be here as long as I had hoped to be here, was present. They were questioning their spirituality, and they also were becoming more socially isolated. During this time, I noticed that everything I had been trained in was missing the mark on these themes that were swirling with my patients. And so I went out into the community. So I probably should have said this at the beginning, as a clinical neuropsychologist, my specialty is supposed to be the cognition, right? I'm trained in psychology, but I'm supposed to really be the person that assesses attention and memory and gives recommendations based on that. So I was like, okay, I don't remember learning a ton about this during my too many years of schooling. And so I'm gonna go into the community and see who is doing this and who can help my patients so I could refer out. And over again, in my own community, the door was getting slammed on my patients and on me as the referring provider. 2 reasons I was hearing from them. One is, well, so your patients have a tumor in the brain, yes. So they must have cognitive impairment. Well, potentially. I haven't been trained in how to work with somebody with cognitive impairment. You'll have to find somebody else. Or, okay, so your patients have a tumor in the brain, yes. Is it curable? Well, they're actively treating it. You know, we're trying. It's life-threatening, but right now they are doing great. Yeah, I'm not willing or haven't been trained. I don't know how to talk to somebody that might have a terminal or a life-limiting illness. So again, it wasn't that they didn't know how to. They didn't feel equipped, or they didn't have the experience or the exposure. So I kept getting no's. So here's 2 years. I had all these patients that needed help and nobody to help them. So that's when my team went into the literature. I said, okay, we're not getting this in Richmond, Virginia. So who's doing it out there and what are they doing and how do I bring it to my patients? So I went into the literature. I looked at all of the information out there. We did what's called a systematic review, which is really where you did this massive review to see what do you know in the literature about this specific topic. Specifically, these topics of fear of mortality, fear of the cancer coming back, questions of meaning and purpose. Out of 132,000 oncology patients examined, okay, in these studies, less than 0.2% were our patients with brain tumors. Less than 0.2%. That was mind-blowing to me. Now, I had some people say, well, brain cancer's rare. Brain tumors are rare. I'm like, okay, they're 1.4% of cancers, so that's still an 8-fold underrepresentation. And instead of being included in these studies, I was noticing they were being excluded. Why? The studies were saying just a blanket statement, nobody with any brain disease can be included in their studies, or nobody with any cognitive impairment could be included in these studies, What was interesting about this one, most of the studies weren't even testing these patients to see if they had cognitive impairment. They were just assuming that they had cognitive impairment. One of my doctoral students did a study looking at the same screeners these other research studies used. 91% of our patients passed these screeners, so should have been included in these trials. And then a lot of them are still going off the old definition of survivor. We know the definition of a survivor is the moment you are diagnosed, you become a survivor. They are going off the old definition, which was either had to be off treatment, which a lot of our patients never go off treatment, and or had to have curative intent for the treatment. And again, we know that sometimes that's not a possibility for our patients. We were able to publish this. If you guys are interested, I can share this later. So this is when I was a clinician. I was in clinic 5 days a week. I was burning and turning neuropsychological evaluations, and I took a pause and I said, okay, I'm gonna continue in my clinic, but we still have a lot we don't know about the psychological health of brain tumor patients. And that's when we created Live Now, which is my research lab. It stands for Neuro-Oncology Wellness, because we decided that this was unjust and unfair for our patients, and we were gonna change that. So I bring up medication, not because I'm I'm not a prescriber, but also I'm not actually a proponent of this, but I bring it up because it remains physicians' first line of treatment for mental health. But in brain cancer, there's almost no high-quality studies showing that it's actually effective in our patients who have mental health concerns. But still, up to a fourth of our patients with benign tumors are put on antidepressants almost immediately after diagnosis, whether they're showing symptoms or not. And nearly half of our patients with malignant tumors are put on antidepressants. Despite the known contraindications, antidepressants lower your seizure threshold, they increase memory impairment, and they increase fatigue in our patients. So I want to say, like, buyers beware. On this, you're not, well, I guess you are kind of buying them, but just be mindful of that. There are other ways and other tools that we can use prior to jumping to medicines, and that's what we're trying to do at Live Now. So let's go over some general mental health strategies that whether you are a patient with a brain tumor, whether you're a carer with a brain tumor, or whether you are just the average Joe Schmo out on the street, these are going to help you in day-to-day life. Exercise regularly, right? I already went over this. It is good for your physical health and is good for your mental health, cognition, and emotions. Maintain a healthy diet. We just heard that up at the last presentation. Usually I recommend more of the Mediterranean diet, high protein, low fat proteins, fish, chicken, vegetables. Limit the carbs, limit the high processed sugars. Not completely eliminate. If you want an ice cream, go have an ice cream. It's okay. But, moderation, 80% try to eat healthy. It's good for your body. It's good for your brain. Get sufficient sleep. Okay, I'm going to give you an analogy I give my patients all the time. I use this every day, all day, everything, right? We all do. We're on our phones all day long. At the end of the day, what do we do with our phones? Anybody? Charge it. Yeah, you plug it in, right? Because in the morning you hope to wake up and it's 100%, and you're hoping, if your battery is good, it's going to last you all day. Think about this for your sleep. Sleep is our brain's way of recharging, okay? If we are using our brain, especially if we are a brain tumor survivor, and we are working harder to use our brain than our peers, when we go to sleep, that is when our brain recharges. If we don't get sufficient sleep and I'm waking up at 60%, I'm setting myself up for failure. Sleep is so important to our brain health. These next two go together. Spend less time sedentary and get outside. Again, it is really good for our emotions, our mental health, to get sunshine, to experience the fresh air. I tell my patients and their partners to come up with a weekly game. How far can I get away from my house? And see if every week they can increase that. Whether that is walking to the mailbox, might be the goal of the week, going to the grocery store, or going to Maine for a month, like we heard in the last session. How far can I get away from my bed, away from my couch? Again, moving and being social getting outside. Ensure your positive social support and engage in pleasurable activities. This diagnosis is heavy. It's heavy for the patient, it's heavy for the carers. Ensure that you are still finding joy in your life. Laugh every week. It can be very isolating when you're going through radiation and you're tired and you're having to go to the hospital every day and you're scared because you have the MRI next week and you've got to get your labs and everyone's telling you to do all of these things. Where's the joy in that? So plan it, put it into your schedule. Get together with friends, go out to dinner, go dance with your loved one, and experience new things and new learning. Learning the same thing over again is not good for your brain. So go out and learn something new. Okay, the next part I want to talk about is advocating for yourself, okay? At the start of a diagnosis or when somebody starts to notice that there are symptoms, mental health symptoms present, ask your physician for a referral. There's all types of providers that can be helpful to you. Now, obviously, not everybody has the benefit of being at an academic medical center, having a clinical neuropsychologist or a psychologist, but most community hospitals or cancer centers have social workers. Nurses are our best friends. They literally spend more time with the patient than the physician does. Talk to your nurse. They have the time and they want to help you. And also, pastors, clergy members, reach out in your community. The reason I say this is because they can start to pinpoint what treatment is good for you. They can determine your symptoms and the severity, and they can choose an evidence-based treatment that is proper for your symptoms. So individualized care. All of these are different evidence-based treatment options that are for the general public. Now, I'm going to share with you, a lot of these actually haven't been fully researched in the brain cancer or brain tumor world. But those that have, we know that relaxation, deep breathing, meditation, mindfulness, and then we get some more of the psychological-based, theoretical, cognitive behavioral therapy, goal management training. I don't have time to go into all of these. It would be a whole conference in of itself, but I just wanted to show you there are many, many options out there that might be the perfect fit for you, and they're not lifelong. Some of these you don't have to go in and work with a psychologist or work with a therapist or a counselor for 3 years. They might be 6 weeks. You learn the skills, you go home and you practice them. Now, I only have a couple minutes left. So what I wanted to do was provide a little bit of hope for you guys that we're not done yet, okay? There is so much to learn about mental health in neuro-oncology. And I wanted to share with you 2 studies and preliminary results that we're doing at Live Now. So one of them is called Managing Cancer and Living Meaningfully. This is a psychotherapeutic intervention that was developed actually in Toronto, Canada at Princess Margaret Cancer Center. It was designed for advanced cancer patients to talk about 4 domains: symptom management and communication with your healthcare provider, which we learned was very important, relationships and how they change, not only within those that you love, but also yourself, finding meaning and purpose in life, and then fears of the future and mortality. So we did 2 very small studies to just look at, is this appropriate? Because guess what? They didn't include brain tumor patients in their trials. And when I went to get trained on this, I raised my hand and I was like, well, what about the data on neuro-oncology? And they gave me all the excuses of why they didn't, and I was like, I'm challenging this. And so I was trained with them, and they welcomed me with open arms. They're actually part of our trial, and so that we can see, is this therapy beneficial to our patients with brain tumors like it is for other advanced cancers? So we did 2 small trials, one with primary brain tumor patients and one with metastatic brain tumors. We found in both it was feasible, fancy term for we could enroll the patients, they were interested, we could keep them in the research study. It was acceptable and beneficial. They were telling us, we really enjoyed this, and we would recommend it to others that are going through the same situation that we're going through. We saw decreased scores in their depression severity. We saw decreased scores in their death anxiety, so the fears of ending life earlier than we expected. But interestingly, we did not see any change in fear of cancer recurrence. So what that told us was this therapy is probably good for some of our patients that are experiencing the symptoms of depression, the symptoms of death anxiety, but it's not hitting the mark on this scanxiety that the majority of our patients experience. So what we've been doing the last year is creating a new intervention called Fearless in Neuro-Oncology. And it is specifically designed to provide coping strategies and reduce the fears surrounding that scanxiety. So we actually, this is our intervention. It is a 6-module intervention. This is a sneak peek. We haven't published this yet. We brought on 2 community boards. So we brought on a professional community board, a neuro-oncologist, nurse practitioner in neuro-oncology, a clinical psychologist, and a patient advocate in neuro-oncology. And then we had a patient and caregiver board. We had multiple patients and multiple caregivers. They were trained in a whole bunch of different fear of cancer recurrence interventions that exist out there. But guess what? None of them have included brain tumor patients. And so we had questions of, A, is this appropriate for our patients? Do we need to adjust things? And are there pieces, like is there one that's the gold star that we should use, or are there pieces that we need to incorporate together? And that's actually what ended up happening. We had to change terminology. We had to change, instead of the uncertainty of things, the certainty of things with our patients, hypervigilance patterns. The checking is very different in a breast cancer patient and very different in a skin cancer patient than it is in a brain cancer patient. Brain cancer patients aren't going around, or brain tumor patients, checking their skull to see if the tumor's back. At least the majority of them, 99.9% are not. But they are coming to me saying, I counted, I couldn't find 5 words yesterday. Or I had a little bit of a headache. That's how I originally found this tumor. I had a feeling of dizziness. Is that an aura? Am I having a seizure? There's different things that our patients are perseverating on. So we created this Fearless intervention, and we are almost complete with our first trial. We are doing 6 patients are going through it. 6 caregivers are going through it because they actually experience more distress than the patients themselves. And we have 6 dyads, patients and caregivers, going through it. So here are our preliminary results. It's taking us about 10 weekly sessions to get through this intervention. They meet one-on-one or in the dyad with the therapist on the computer screen. It's all telehealth. So actually our next recruitment will be national. It will not just be at our cancer center. We are finding that those that have completed the intervention, actually, let me go back to this real fast. I know I'm out of time, but I only have a couple more slides. We filled this patient arm immediately. I think that within the first 2 weeks of having this trial open, we had all 6 patients up and running. It has taken us months to fill the caregiver and the dyad arm. So of those who have completed, we've had only 2 withdraw. Both of them were caregivers. 1 withdrew prior to actually starting because something happened with her patient and she did not, or her loved one, and she didn't feel she had the time to give to this intervention. Another one was withdrawn actually because their internet went out, and we tried for 6 weeks and we could not connect with them. So again, anyway, of those who have completed, 100% have completed our post-session surveys that give us the data on whether this is helpful or not. 100% of them have described this intervention as beneficial. 100% said they would recommend it to others. Here's the interesting part. 33%, so a third of our patients actually said, I think I want the intervention to be a little bit shorter. 10 weeks is a long time to commit to. But half of our caregivers said they would recommend a longer intervention. So we had a harder time getting them in the door. But once they're in the door, they realize how much they need it, and they don't want to let us go. So this is food for thought for future interventions. Now, here's the most important part. At this stage, honestly, we have small numbers, right? 6, and 12. So we can't really hang our hats on this yet, but we're just looking, is this moving the mark? Is this intervention targeting what we want it to target? 90% are showing a reduction in fear of cancer recurrence. And this is based on questionnaires, what they're reporting to us, anywhere from a 4-point reduction to a 50-point reduction, which is like half of the questionnaire. So we're tapping into something here. This is what they're telling us. My approach to reoccurrence is different now. I recognize and I respect it as a possibility, but my emotions towards it, I don't spiral into it. I respect it as part of my life, but I don't dwell. My level of concern is about the same, but now I feel better equipped. Another patient said, this program makes me feel like there are other people going through this and that there was someone to equip me with the skills now to finally get through it. And then a caregiver. I was just excited at the prospect of having more support through this experience. There isn't really support for caregivers' emotions when a family member is sick. Okay, so I'm all done, but I just want to leave you with 4 things real fast. The first is I want to validate every single one of you that a brain tumor diagnosis can impact your cognition, okay? Your thinking does change through all of these treatments. I want to validate you. You're not going crazy. There are physical changes happening. I also want to validate you that a brain tumor diagnosis can impact your emotional health as well. But there are things that each of you can do to support both. And there are people, there are clinicians like myself and the amazing organizations like ABTA that want to help you, so reach out to us. We are not done, okay? And we will not stop researching this and finding things to help you until brain cancer is cured.
We have now time for questions. If you just stand up since this is not working, and I will call on you. It's working now, 1 second.
First of all, you did a really great job on your presentation. Thank you. I don't know how much all patients are getting neurocognitive testing at this point. My question is a 2-part question. A, what's the importance and value of neurocognitive testing at the time of, around the time of evaluation? And then the second question is, what's the value and benefit of a long-term survivor of some cognitive testing as well?
This is a great question. Thank you. I agree, not enough are getting it. There are probably 10 to 12 of us in the nation that are neuropsychologists that actually specialize in brain tumors, okay? There are plenty generalized neuropsychologists. Unfortunately, their waiting list is like 6 months to 12 months, which is not really helpful in the brain tumor world. What is the importance of diagnosis? Is that what you, yeah. So the importance of diagnosis is for us to establish a baseline as much as we can. Obviously, the baseline is really 5 years prior to diagnosis. We don't have a time machine. If somebody invents that, it would be helpful. I would appreciate it. But it sets us up for understanding where a person is functioning and then really for the future. So that first cognitive assessment is really just, how are they doing now so I can compare it to later? Okay? The importance of serial testing is to see how the treatments are impacting the brain and so that we can start implementing some of these strategies early on and when they're needed. Also, I can't tell you how many brain tumor boards that I've been to that I have spoken up with the room of physicians and I have said, we are not going to radiate this patient again because it is going to throw them into dementia. So we have to find something else because their memory scores were right on the cusp. And if you go in and you radiate this part of the brain, they are not going to be able to function independently. So you need to have that conversation with the patient and the carer and let them decide what the next steps are. For long-term survivors, the importance is, can I go back to work and when? Can I drive? Do I need disability benefits? Because we can support that if that is needed. And what accommodations to go back to school? I have had many that want to go into law, want to go into medicine. What do I need during med school and law school to help support my brain's functioning now that it has changed? If you don't have a clinical neuropsychologist, speech and language therapists can also provide these kind of cognitive evaluations. They might not be specialized in brain tumors, but they're specialized in brain injury. And a lot of community centers have that. Great question.
Hi, I'm Wendy. I just wanted to mention I have 22 years of CNS lymphoma. I just had a brain tumor MRI this July 6th. I do use my app I have aphasia, so I'm not good with words. And they took a golf ball size out of my brain. So anyways, I do plug in my computer. Oh, God. I plug it in to be able to recharge it, and I use it with my sleep to put it on my time and have it charge overnight or whatever, and so that helps me, one. And two, when I went in recently for the MRI, I used to fear, similar to what you're referring to now and everything, because it's been since 2001 I got it. And they thought I had glioblastoma, blah, 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 it took ages. But in the meantime, I went in recently for my MRI, and I fell asleep. That's how I didn't have that fear. And it used to really get me every 6 months when I would go in. Yeah. I would it would make me crazy. And God bless, I fell asleep. I had the headphones on. Yeah. And for today, you know, I don't know what tomorrow will bring, but for today, I didn't have that fear, and I fell asleep, so.
Thank you.
Early in your presentation, you talked about the neurotoxicity of anticonvulsants, and I'm wondering, for something like gabapentin or whatever, is it within certain ranges that it creates neurotoxicity, or across the board? And also, what are the measures of neurotoxicity to say that it's causing any anticonvulsant?
Yeah, that's a great question. So I do think it's person dependent. That's, you know, obviously the higher doses are going to have more risk of causing neurotoxicity. I was specifically talking about cognition. So the tests are going to be the memory test, the attention test, and we do see that there is a negative effect when somebody is on an anticonvulsant, especially for memory. But, you know, again, with our patients and our population, you have to weigh the risks and benefits. If somebody were to say to me, well, does that mean I should come off my anticonvulsant? I would say probably not, because then you might have a seizure, which is going to damage more brain and also impact your independence in life. And so, you know, you have to talk with your physicians about the risks and benefit of them.
We have time for 2 more questions. We had one here and then one up front.
Hello.
Hi.
I just had a question about mental health. My husband was newly diagnosed with a GBM, and I know you said things like surveys or how do you provide counsel, and I just want to know what was more important to tell a patient or give the patient. Is it education or is it comfort? Because I think going into the offices now, it's like they want to comfort me, you know, and so they'll give me the short end and it's going to be okay, be positive, things like that. But most of the time I want to go in for the education so I can be prepared to, you know, cope or comfort, you know. So I was just wondering what you guys teach.
I actually think a blend, both. It's something I call double awareness. I didn't key that term, but this is what I explain to my patients. It is finding the balance of living meaningfully and purposely while knowing we might have a terminal diagnosis. And how do you hold both of them at the same time? So I think it is very important to continue to instill hope, right? The numbers in a textbook are not your husband, right? And they are not you, and they are not you. But this is what we know. So I'm going to give you as much information as I have so that you can live meaningfully and purposely with that knowledge. So I think it's a balance, and I think you have to scatter both at the same time. You can't just go in and give them all of these Google statistics, which are going to scare them to death, but you also have to make sure that they understand the realities of this diagnosis so that you can plan and live purposely and meaningfully. Because life might change in that regard, right? If I heard that, well, I know my father was diagnosed with lung cancer, it had already spread to his brain, and we lived a very different life the last 6 months of his life than he was living before, and it wasn't all because of his physical. It was purposeful decisions we made as a family to make memories and have experiences while we could.
I'll say thank you so much for the lecture. This is one of the best I've heard. You triggered on something that I wanted to ask a question about. The whole idea of the radiation and taking you over that level to possibly a dementia later on, because I had a decade of MS and the mush of the lesions on top of the 6 years with my tumor. So unfortunately, I do know that there's an agenda on the one side that's going to say, no matter what, you need to do the radiation. Who do I go talk to find that other line and test and figure out where I really should be? What kind of doctor?
To determine where you are memory-wise?
Right.
So the gold standard is neuropsychologist. It's somebody who is a clinical psychologist but has extra training in how to test cognition and understands brain functioning. If your local center, if you have an academic medical center, hopefully they will have some or can connect you with one. If they don't, a speech and language pathologist. So a speech therapist is also trained in a lot of not just language tests. They do memory tests, they do tension tests. They know how to do all those tests and can provide at least a general overview of where your cognition is. So they, again, like Dr. Dunbar was saying, it's data for your physician. More data is important for them to decide what's best for you moving forward, at least what they're going to recommend, because I want to remind you guys are in the driver's seat for what treatment you get next.